Good evening, everybody, and welcome to tonight's Facebook Live of Breast Cancer Now. It's my absolute pleasure tonight to be joined by Dr. Vanessa Clay, who's a consultant medical oncologist at the Christie in Manchester. But before we meet Vanessa, just a couple of housekeeping things. There is the chat box, so if you have any questions for Vanessa during our live, please do post them in the chat, and we'll answer as many as we possibly can. If we don't get round to answering your questions, then we will send you a written reply, but that may take a few days to come back to you, and will be next week. Of course, if you need any help and support, our helpline is open Monday to Friday, 9 till 4, and on a Saturday, 9 till 1. And the number is 0808 800 6000. So please do know that our nursing team are here to support you. There will be an evaluation form at the end of the live, so if you'd be kind enough to complete that, we'll be really grateful. It's really important that we know what works for you, and if there's any other topics you'd like, or even what time works, then please, all your comments are gratefully received. So, without further ado, it's my absolute pleasure to welcome Dr. Vanessa Clay. Hi, Vanessa.
Hi, Vic. It's lovely to be here.
It's really lovely to join us. Thank you for giving up your time tonight. We really appreciate it. So, Vanessa, I think we'll jump straight in. But on the helpline, we hear quite a lot of questions from people about their breast cancer treatment, and many people have questions about immunotherapy. So I'd wonder, why don't we start? Are you able to just give us an overview of what immunotherapy is?
Of course. So immunotherapy is a relatively new treatment for cancer, and it started in some other cancers, to melanoma and things like that to start with, and we saw how useful it was and how powerful it was. And it works very differently to standard chemotherapies. So if we go back to kind of the basics, when you form a cancer, those cells are abnormal. They are not normal, healthy cells. And in theory, your body should recognize them as abnormal. And when your body finds abnormal cells, typically, so an abnormal bacteria or anything else that's abnormal, it destroys it. That's what your immune system does. Now, cancer cells are abnormal, so your body should recognize them. But unfortunately, cancer cells are also quite clever and often display proteins on their cell surface, which means that they can hide from the immune system. So the immune system can't see them and can't destroy them. And immunotherapy is a way that we have developed to try and target that and to make these cancer cells more visible to the immune system so that your own immune system can fight these cancer cells and destroy them. So that's a broad overview of what immunotherapy is. Now, there are lots of different types of immunotherapy, and only some of them are used in breast cancer. And that's because only some of them will work in breast cancer. So other types of cancer cells work differently and express different things, and we target them in a different way. So with breast cancer, we are looking mostly at two types of immunotherapy. One's called pembrolizumab and one's called atezolizumab. I hope that kind of gives you a brief overview in terms of what immunotherapy is and how it's different to chemotherapy.
Yeah, so that's really interesting, and thank you for explaining that so well. So Vanessa, if you were talking about, so you've explained immunotherapy, why might chemotherapy be given alongside immunotherapy?
And that's a really good question, and it's can be quite a complex answer. So we think the short answer is we think the immunotherapies work better when they're given alongside a chemotherapy for breast cancer. We have tried them in other ways in trials. So all of our treatments for breast cancer are based off trials. So we try different things in different regimes when drugs are developed with and without chemotherapy. And in breast cancer, we feel they work better, at least initially, with chemo. And that's probably because as we give chemotherapy and we're destroying cells, we are releasing some more of these abnormal proteins that are sensitizing the immune system, therefore making the immunotherapy more active.
Right, so the two work well together.
Yes, I think that certainly in breast cancer, that's what we see.
Yeah. And we had a question in actually from Susan, and she's saying, do you always have to have chemotherapy with immunotherapy? Can you have immunotherapy by itself?
in breast cancer, we always give the two together to start with. And then if the treatment continues to work, so in metastatic breast cancer, if the treatment continues to work, we will stop the chemotherapy at a certain point and just continue the immunotherapy for as long as it continues to work. And in early breast cancers, where we use immunotherapy with chemotherapy in triple negative breast cancers before surgery, we continue the immunotherapy after surgery. So there are periods of time where you just have the immunotherapy, but in breast cancer, in both early and metastatic breast cancers, you always receive the two together.
Two together
Now,
to
that
stop
is
the
different in other cancers. So often we have patients with relatives who have different types of cancer that will say, my father, whatever, is just receiving immunotherapy. And that's because trials in that type of cancer have shown that that's enough and that's effective, but it's not the case in breast cancer.
I guess, Vanessa, that shows the complexity of it. You know, in immunotherapy, like you say, it's relatively new, isn't it? But it's advancing so much all the time. But different proteins, different treatments for different tumor groups. So it's really important, isn't it, to be able to discuss your treatment so you understand what you're having and why.
Yeah, I think that is really important, Vic, when you speak to patients, that they really come away from it understanding why they're receiving this treatment or why they're not receiving this treatment,
Mm.
particularly because so many people sadly are affected by cancer and a lot of conversation happens, and we wouldn't want our patients to go away wondering why they weren't getting X or why they were getting Y.
Yeah, and do you know, Vanessa, that's timely because we've had a question in from Anna who's said I've been told by my treatment team I can't have immunotherapy. So obviously, Vanessa, you haven't got Anna's notes and we don't know her whole story, but what might be the reason for Anna not being, if you say, eligible for immunotherapy?
Yeah, so as I've alluded to, the development of these treatments has come from trials and what works and what doesn't. And the trials have shown there are certain situations in breast cancer where the immunotherapy doesn't work and doesn't add anything, but may expose somebody to side effects. So thinking about Anna, it obviously depends whether she has advanced breast cancer or early breast cancer. In advanced breast cancer, we actually test the cancer cells for the presence of these proteins that are helping the cancer cells hide from the immune system. And if they're present, we think they'll benefit from immunotherapy. And if they're not, then there's no value in giving that treatment. In earlier breast cancers, we are interested in the type of breast cancer. So we know that there is no, currently, as with the treatments we give and based on the trial information that we have, we don't give immunotherapy in hormone receptor positive breast cancers, for example. So that might be the case then in
Right.
others. It's very difficult. But yes, it is
Yeah.
all about the trials, where we found the evidence, where we found that these treatments work, and not exposing patients to these treatments with the potential side effects if they're not going to get any benefit.
And that's such a good point, isn't it, Vanessa? That we know there are all these drugs, but I think what's happening in the breast cancer community now and research is it's getting more targeted, isn't it? So that it's more individualized according to the uniqueness of specific cancer cells, because there are similarities, but there's also so many differences as well. And like you
That's
say,
correct.
I think there's more research now about why you expose your patients to those side effects if actually the benefit is not there.
That's exactly it. And you're right that breast cancer is, it used to be considered a disease with potentially three subtypes, but now we realize there's so many more and so many different
Mm,
pathways we can target. And we've now got a lot of the technology is coming, certainly, to be able to find these different things that we can test and target, and
mm.
treatments will become much more personalized.
Yeah. So the protein you talk about, that's PDL1, is that right?
That's
Yeah.
right, yeah.
And
Yeah.
so there's a test for that, but you would only use that in patients who have secondary or metastatic breast cancer.
That's where we
Yeah.
test for that, yes.
That's right. That's good. That's good to clear that up. Now, Vanessa, we've had a question in from Jackie, and which ties in quite nicely actually about what we were talking about. So, Jackie's, oh no, it's not Jackie actually, it's Hera. Sorry, Hera's saying she's got recurrent, metastatic triple negative breast cancer, and she's asking what is the other option if immune therapy isn't working.
So, with all breast cancer treatments in metastatic breast cancer, we try them for a period of time, and eventually we know the cancer cells become clever, if you like, and develop ways to grow despite these treatments. And that certainly can happen with immunotherapy, as it can with all the others. And there are other options, usually, depending on the treatment, the diseases and the treatment that's been given so far. But usually that would centre around different types of chemotherapy in triple negative breast cancers. Again, so we sometimes use things like capecitabine or eribulin. There are some newer treatments as well. So we now may have heard of Trodelvy or sacituzumab govitecan, and that's a really interesting drug that's an antibody drug conjugate. So we are targeting a very specific protein that's present on triple negative breast cancer cells, and with that we are giving a chemotherapy drug. And so that can be an option. So there are options certainly when immunotherapy stops working.
But just to in here his question, so you mentioned two types of immunotherapy drugs that you use, the Pembro and the Tezolizumab. Can you use one and then another, or is it just
Yeah, so in late breast cancers we use the atezolizumab. There is no evidence to suggest that using another one after that would offer any benefit, so we
right?
don't do
So it's
that.
just one line of treatment. Oh, that's
But
okay. So,
currently, yeah.
yes,
Whether that will continue to be the case, I think there's a lot of work looking at next lines of immunotherapy currently, but as things
right.
stand,
And it's
this is
quite incredible, Vanessa, isn't it? You know, you talked about Trodelvy, and I know breast cancer now are quite heavily involved in getting that, to market, so to speak. But it's amazing, isn't it? The amount of drugs, new
how
drugs that are.
quickly, and how, as consultants, we are constantly surprised by the volume and speed at which things are coming out,
Yeah,
and the things that we can now offer our patients that we couldn't do just a short number of years ago.
yeah. Keeps you on your toes, Vanessa.
Certainly does.
And you mentioned so we talked about one line of immunotherapy, and you mentioned targeted therapy. And Susan's asking a question: how are immunotherapy and targeted treatments different?
I mean, it's a really good question, and you see people use targeted therapy, the phrase, in different ways, and um, we perhaps don't need to get too caught up in the wording of things. So, in many ways, immunotherapy is targeted. It is targeting PD-L1, PD, and PD-1. Um, I think chemotherapy isn't targeted. Okay, I think that's probably quite straightforward. Chemotherapy is not specific to any pathway. And there are some treatments that are more specific, so things like the CDK4/6 inhibitors, they are targeted. You could call Herceptin targeted because it's targeting the anti-HER2 receptor, and immunotherapies are targeted in their own way. So I think
Right.
targeted therapy is it can be quite a broad term, and I have seen it used in many different ways by consultants and in the literature. So I'm not sure it's terribly helpful.
No, it's confusing, isn't it? Like you say, and maybe targeted therapy is an umbrella phrase or,
It
or
is.
term for, and then there's individualized one from that. But like you say, it is confusing, and it takes quite a little bit of reading, doesn't it, to actually work through the terminology. So, but thank you for sorting that. So we have now a question from Jackie, who I mentioned earlier. Now, Jackie said, do the side effects subside after a while? And I wonder if it's worth Vanessa just talking about what the side effects are.
So, referring to immunotherapy, the side effects of immunotherapy can be very variable. So, I would say that most patients tolerate it very well and can experience no side effects at all. Um, but immunotherapy, as I've said, works by making sure your immune system can see cancer cells more clearly and kill them. But the side effect of that is that the immune system can become too active in many ways and can then attack other organs, other healthy tissues. Very similar to other autoimmune conditions that people suffer from outside of cancer, and they affect lots of people, very separate from cancer, things like thyroid disease and other things like that. These immune therapies can cause these problems. Um, I wouldn't say that they usually settle. They usually do require some intervention, and by that I mean often potentially some steroids to quieten down the immune system to try and turn off that attack. The kind of common organs that we see, so we do see thyroid disorders, relatively common, where people end up needing long-term thyroid medication. It's less than 10% of people, and we monitor for it in blood tests regularly, and is very easily managed, but it's certainly something to be aware of in terms of the side effect profile. We also see diarrhea, and that's labeled colitis, where that's an inflammation of the bowel, because again, the immune system is attacking that area and causing these symptoms. And we'll sometimes see pneumonitis, which is a word for inflammation of the lungs. But essentially, inflammation can occur of any organ as a result of this immunotherapy, which makes it very difficult to predict and sometimes to help patients understand and recognize what's happening. So we certainly say that if you have any symptoms at all with your immunotherapy, you need to contact your hotline or whatever hospital contact number you have. And it's really for the specialist to work out whether this side effect is because of the immunotherapy and whether that needs further support or treatment. But coming back to Jackie's question, do they tend to get better? There's obviously a huge range of side effects, and I don't know what Jackie's referring to, but most of the immunotherapy side effects would require some intervention. If they are very mild, then we can observe them. So a small amount of diarrhea, less than 3 times a day, we would potentially just observe. Skin rash is quite a common mild side effect of immunotherapy that we would continue, but I'm not sure I'd expect it to settle. We would just tolerate it and manage the symptoms.
And Vanessa, so if a patient has side effects such as a rash or something, would you still continue with the immunotherapy? When's your cutoff for stopping it?
So there are some excellent guidelines that are European, and we adhere to them. So there are situations where we continue, like so with skin rashes, and that depends on how severe it is, and that's the case of all of these side effects. So how severe is it with skin rashes? How much of the body it's affecting? How red the skin is? How sore it is? And at certain levels, we would continue. At certain levels, we would continue and give us a low dose of steroids. But if things are requiring a higher dose of steroids to control the side effects, then that's the point we think we need to pause, certainly. That's not to say they can't be restarted in the future. And again, that depends on how severe the side effects were at the time.
Yeah. And sorry, Vanessa, I'm interrupting. If you stop treatment and then restart it, is it likely that the side effects may happen again, or do you
It's
see
certainly
them?
possible, yeah, for them to recur, and your consultants will talk to you about the risks, because with all of cancer treatment, it is a risk of benefit, versus the side effects and the toxicity.
Absolutely, yeah.
So if the treatment was working well for you, there may be a pause and you can restart, but there would be a conversation about these side effects could recur. We don't know. But if the side effects were very severe, then we might feel at that point the risk is too great, not worth the benefit.
Yeah, and you're right, aren't you? It's very much that balance, isn't it, between treatment that is treating the breast cancer, but also quality of life, and it's that balance, isn't it? And we see that a lot. Yeah,
Sometimes that's individual, so they're really important conversations to have with patients. Somebody's idea of good quality of life is not somebody else's, and
yeah.
together it's about those joint decisions, I think.
Yeah, absolutely. Yeah. And I think what I've heard from you there, Vanessa, as well, is that because the side effects of the immunotherapy can be quite slight, it's really important that people are aware to contact their hotline or their 24-hour number if they feel unwell or just something's not quite right.
Because we know that sometimes if we leave these side effects untreated, they can become worse, and
Mm.
the sooner we treat some of them, the better.
Yeah, yeah, that's really helpful. Thank you. So Amy's asking, can you say what the names of the immunotherapy drugs are?
They are a mouthful, but the ones we use in breast cancer are pembrolizumab and atezolizumab. I can see that Amy's also asked about tamoxifen and anastrozole. So they aren't immunotherapy drugs, they are endocrine therapy drugs.
So they work in a very different
An
way.
entirely
Yeah.
different way.
And that just shows the complexity again, doesn't it? Yeah. And we were talking about side effects, and Karen's asking, how commonly are you seeing multiple side effects with immunotherapy, and how often are you seeing these side effects longer term? And I think we've sort of answered that, haven't we, really, Vanessa? But it's an interesting question, isn't it, that Karen's asked about multiple side effects.
So we do sometimes see, it isn't common, but we do sometimes see, for example, if somebody experiences diarrhea and colitis, we watch very carefully their bloods because we sometimes see other organs then being affected as well. So we can sometimes see some inflammation in the liver or the kidneys. So we are very careful to look for those other things, certainly once we see a side effect. And in terms of seeing side effects longer term, we hope with the treatment for the side effects, so often that's steroids, but there are other lines of treatment for side effects as well. So occasionally the side effects don't respond to steroids or respond but not quite enough. So then we can go in with other lines of immunosuppression, again, to try and turn off this immune system response. We hope if we get that treatment correct, then we should really eliminate that side effect entirely. It's less likely to see longer term grumbling side effects if managed properly with good immunosuppression.
And again, that just highlights, I'm going to reiterate again, isn't it, the importance of seeking advice if something's not quite right, because it can then be managed, can't it? Or the chances for it being managed are more successful if it's caught early. Yeah, that's good. Now, Shelley's asking, is what's that? Verzenose, how do we say that? Verzenose, an immunotherapy drug?
That's abemaciclib off the top of my head.
Oh, okay. Okay. Oh my God.
And no, that's a targeted therapy, which is a CDK4/6 inhibitor, which targets that pathway and again is used in her hormone receptor positive breast cancer.
It's such a good question to ask, even though I'm rubbish at pronouncing the name, not going to lie.
I'm glad you tried that because we never use the trade names.
That's easy. But it shows, doesn't it, the not the confusion, but the links between immunotherapy and targeted and how they, and it's, really differentiating that, isn't it, is so important. So let me have a look. Oh, Deb has asked a question, Vanessa. Am I at risk of infection when I have immunotherapy?
It's a really good question. I think it's quite a complex question. The simple answer is it's not the same as the chemotherapy. So the advice about doing your temperature every day and we don't do blood tests looking so much for a low white cell count and things like that. So the shorter answer is it's less of a worry, and we don't see that neutropenic sepsis, those admissions with temperatures and things that we see with chemotherapies. But undoubtedly, the immunotherapy is doing something to your immune system. Whether that leads to a slightly different response to certain infectious agents is difficult to say, but it's certainly not in the same bracket as chemotherapy. So we don't give the same advice about temperature monitoring, etc.
And actually, Vanessa, we had an interesting question the other day that was on our helpline that. So obviously there's vaccinations going around at the moment, COVID and flu injection. Are they safe to have when you're having immunotherapy?
So our usual advice is yes, but speak to your oncologist about the specific vaccine that you want to get because there's a big variation in the vaccines. Some of them are, of different types. So speak to your oncologist for vaccine advice, but broadly speaking, yes.
Okay, and that ties in with Leslie's just asked a question. I was told my daughter couldn't get the flu spray at school as I'm receiving immunotherapy. Why is that?
So the flu spray off the top of my head is a live vaccine, so they might have been a little bit more cautious about that. But from memory, the standard flu vaccine is not live. But
Okay.
again, the different vaccines are offered around in different regions to different people, so it's important to speak to your oncology team.
Oncology team and also maybe even the school nurse or someone who's doing the flu spray at school. I hope that helps, Leslie. And I can see Jenny's asked a question, and I can see from reading Jenny's question it's not actually related to immunotherapy, but I think it would be good to answer it. So Jenny's asking, I'm having Phesgo and denosumab for 2.5 years. Will I always have it, or is there a cut-off point? Sort of deviating a little bit from
Yeah, no, no,
immunotherapy, but
that's
it's still a
okay.
good question.
Well, it sounds like, Jenny, the Phesgo and the Dosmab are really working for you for you to have been on them for such a long time. And I can see you've written NED, so no valuable disease, in the question, which says that they are clearly doing what we want them to do. Stopping them is a tricky area. So there are a number of patients that manage for many years on this treatment and have no visible disease on a scan, and then that does raise the question: should we be stopping this treatment? And patients sometimes have very strong feelings about that. Some of them want to stop it because they don't want to keep coming, and some patients want to continue it because they feel like it's working. Um, we don't have we As you've probably heard me talking a lot about trials, and that's what we love as oncologists. We don't have a huge amount of data for patients that manage many years without any further disease growing, so it's very difficult to know what to do, and we tend to make a shared decision with the patients about what they would like to do in terms of continuing. At 2.5 years, I would still continue those, and keep going for your regular CT scans. But if things continue to be positive over the next few years, you can certainly have those conversations with your oncologist.
That's really useful. Thank you. And thank you for asking that question, Jenny. No, Jane's asked a question. She has triple negative breast cancer and has been offered immunotherapy. So she's asking, how long will she have the immunotherapy before her surgery, and how long afterwards?
So we give it. So this is a neoadjuvant lady, is
Yes,
it?
yeah.
Yeah. So the total duration of the immunotherapy is 1 year. So you'll have a period of that beforehand, and uh, that will probably be in the region of 5 to 6 months, and then finish that after your surgery and radiotherapy. That'll be restarted
Right,
to,
okay.
to complete the full year.
Complete the full year. That's really helpful. Thank you. I hope that answers your question, Jane. Now, Melanie's asking, is my ribociclib immunotherapy?
No, that is another CDK4/6 inhibitor, very similar to the abemaciclib. It's just a different drug of the same class that target this pathway in hormone receptor positive breast cancers.
Okay, and there is information on our website about immunotherapy, so do please read that. And also, Cancer Research UK have some very good information about the umbrella term of targeted treatment that you might find useful. So, we've got a question in from Louise. Louise has hormone breast cancer and had chemotherapy and started immunotherapy once I finished radiotherapy. Is that normal, or should I have it alongside the chemotherapy?
Not sure what she means by immunotherapy. I do wonder if she's referring to CDK4/6 inhibitors again.
Yes. Yeah.
Um, I think without knowing a bit more about Louise's care, it's difficult to answer that.
Yeah, Louise, if you're listening, please do call our helpline in the morning, or I can respond to your question tomorrow as well. But I think, Vanessa, because Louise has she's saying
Yeah,
hormone breast cancer, that's
yeah.
suggesting it's hormone positive, so maybe it's not the immunotherapy, but we can help demystify that for you, Louise, no problem at all. Now, Carol's asking, is it okay to get live vaccines if you have breast cancer? I had a COVID jab on Tuesday, and I've also to get a shingles jab before I start chemo.
So the COVID jab is not a live vaccine, and the shingles vaccine, again from memory, I'm certainly not a vaccine expert. I think there are two types of shingles vaccine. One is live and one isn't. So, and I'm not sure the context in terms of your chemo. It sounds as if your oncologist advised you to get these done before you start, which is good advice. Around chemotherapy, so not talking about immunotherapy now, we are very cautious around live vaccines, and we don't recommend live vaccines around chemotherapy usually. But I think from what you've said in terms of COVID, and depending on which shingles jab you have, that should be fine.
Fine, yeah, before treatment, isn't it, Vanessa? Yeah. Now, Wendy's asking, I'm on a combination of nab-paclitaxel and atezolizumab with the hope of shrinking the tumour. What is the success rate of this treatment?
That's a good question. And the yeah, so I would have to go back to the trial to find out the exact percentage of the success rate. But from my experience of treating patients, most patients initially have a response to this treatment. The the question really is about how durable that response is and how long that lasts for, and that can be very variable. Success rate is again, I don't, how do you define success? But for us, that means that the cancer isn't growing, or is shrinking. So I think you it comes down to how long will these treatments work for, and that can be quite variable. Some patients, I have a number of patients that have finished the chemotherapy and continued on the immunotherapy, and some that have managed to do that for a very long time, and others that sadly haven't managed so well just on the immunotherapy, and we've needed to change therapy. Quite a bit more after the first scan in terms of how well people are responding.
And scans are really important, aren't they? I know they can be hugely anxiety inducing, but scans are so important, aren't they? In how you measure. When did you use the word success? And maybe that's, yeah.
No, they are very anxiety inducing, and I think we think carefully now about when they're necessary. We don't want, and it's nothing to do with, a lot of people think it's to do with the cost of the scans, but it's to do with, what are we going to do with the results? Is this going to help us? Is it worth putting somebody through that process?
Absolutely, yeah. And I think traditionally, Vanessa, 3 monthly CT scans, isn't it? But there are occasions where you may choose maybe 6 monthly or less, and that's okay too, isn't it? Yeah.
Exactly, yeah. So, and again, that depends on the treatment that you're on, how long you've been on it, and sometimes, again, shared decision making. Some patients really hate coming for scans, and we can kind of talk about that in your consultations and work out what's best for you.
Yeah, absolutely. And it's all about talking, isn't it? So it's important. Now, we had a question in from Sally. Sally says, I work on a ward in hospital. Is advised to go back. Oh, I guess Sally's asking, is it okay to go back to work whilst on immunotherapy? Which I think ties in with our risk of infection, doesn't it?
Yeah.
So,
So yeah, I think if you're just on the immunotherapy part, not the chemotherapy part, and you're feeling well, and you have good support and good employers, and they understand that sometimes you might not feel up to it, or whatever around that, then yes, we certainly say if you feel up to it, that would be not an unreasonable thing to do.
So really, from a medical point of view, there's no reason. But we do know that fatigue can kick in, can't it? Cancer-related fatigue
And
it's a recognised concept, isn't it? So it may be, yeah, from clinically it can, but looking at the whole of Sally holistically,
that's it.
it's
And it's the coming for the visits and the blood tests, and and things like that. And but I also have patients say to me, if I wasn't going to work, I would find this very difficult mentally. All you think about is cancer. I need to do something else, and we definitely
absolutely.
recognise.
Yeah, absolutely. And so I think, Vanessa, you've really summed up the importance of talking to your treatment team, the importance of seeking advice, if something doesn't feel quite right, and how important that is. And we often hear on the helpline, Vanessa, oh, the nurses are busy or they're busy. I don't want to trouble anybody. But I'm hearing from you quite clearly, it's really important that people communicate and, you know, explain to you, because as a consultant there's a lot that you can help people with, isn't it? But
Yeah.
only if you know about it.
That's it. Yes, we are definitely here to support and try and tailor your treatments to you and to your life and to what you want to achieve. And we can't do that without communication and understanding what's going on.
Yeah, brilliant. Thank you. Well, we've come to the end of our session tonight. So I just want to say, Vanessa, thank you so much. We've covered so much. You've covered so much, I must say. And we've also just immunotherapy and also targeted treatment and also issues with chemotherapy as well. So thank you so much for taking the time to do our live tonight. Really appreciate it, and such brilliant advice. Thank you, Vanessa.
Thanks, Vic.
It's
Thank you for
been
inviting
such a
me.
pleasure to have you.
Okay,
So
thank you.
before we go, I just want to let you know that our next Facebook Live is next Tuesday, and that's on neuropathy and fatigue. So do join us then at 7 o'clock next Tuesday. But until then, please, if you can complete your evaluation forms, know that we're here to support you on the helpline, and we hope to see you soon. Take care. Bye.